Great. Welcome, everyone, and good morning or good evening, wherever you are. I'm thrilled to be here today for this seminar. And I think it would be great if folks who are attending could introduce themselves on the chat so we can tailor the conversation or the discussion later to accordingly. And also feel free to type in questions, comments, and so on over the duration of the talk. So for the last few months, our team at the Johns Hopkins Global Health Initiative, at the request of the Gates Foundation, conducted a rapid assessment of digital platforms that are largely being used in low and middle income countries to respond to COVID-19. So during the discussion today, I will go over the details of several of these platforms, but more importantly, I'll go over in some detail the assessment criteria that we pulled together to understand how ready these platforms are for the purpose of COVID-19 response. So for our purposes, we've gone over 9 platforms that are fairly popularly used in low and middle income settings, but I realize that there might be a lot of proprietary software that decision makers are considering, and this assessment framework that we'll talk about can help as a decision aid as you're making critical decisions on how to think about choosing a platform that might be appropriate. Hi, Derek. So, okay, so the assessment's geared towards decision makers who are tasked with choosing a system. And in the latter half of the talk, we'll discuss a number of technical details that we can deconstruct as needed based on the questions folks have. Great, so let's see if I can, okay. Great, so let me start with some background. With COVID-19, as we know, countries and health systems are not just dealing with the direct impact of COVID-19, but also the indirect effects related to the COVID-19 exposing the vulnerabilities of in the public health infrastructure. And healthcare systems in every country, they're faced with a disease that we're still trying to understand, where the risk factors and the protective factors are still poorly understood. And public health agencies are scrambling to respond to contain the pandemic. And this isn't just in low and middle income countries, even in the city where we live in Baltimore. I think public health officials are actually often faced with a wide range of digital platforms and vendors promising all sorts of tricks and advanced functionality. And it is quite a paralyzing decision trying to figure out what would make sense given the situation. So digital platforms can support case management and then the process of listing, notifying, and monitoring contacts of the confirmed cases. There is evidence from the 2014 Ebola epidemic that highlighted the challenges of paper-based contact tracing. Alan, are you able to admit people as well?
Yeah, don't worry about it. I'm okay. Therese and we're managing that.
Okay, perfect. Great. So going back to the Ebola epidemic, right? So the challenges, it really highlighted the challenges of paper-based contact tracing, and which did result in several delays in communication and response related to incomplete identification of contacts, as well as loss of contact lists by virtue of them being paper-based. As you know, that the period of tracing and notifying the contacts of confirmed cases to quarantine themselves is limited. There cannot be delays in notifying them. Otherwise, there isn't the same efficacy since the contact would have already reached out and been in contact with other folks and so on. So employing digital tools for case management and contact tracing can facilitate effective identification, detection, reporting, and timely analysis of cases and contacts. Okay. Great. So in the early days of the pandemic, we noticed that there was a large influx of apps for COVID-19. each with a range of sophisticated features. As I mentioned, we observed this in our city of Baltimore, but also globally, I imagine that governments are dealing and grappling with the same challenge. And in an effort to address to some extent this gap, the Gates Foundation requested that we conduct a rapid assessment of digital platforms that already have an established presence in several low and middle income countries, and that can be rapidly reconfigured to address COVID-19 case management and contact tracing needs. So we worked with 9 core digital platforms for the purpose of this report: ComCare, Community Health Toolkit, DHIS2 Tracker, GoData, Opensrp, ODK, RapidPro, Sourmaz, and Veltel. If you worked with these before, I imagine I know a few folks already on the call who have. It'd be great if you can type that into the chat, and we would love to hear from you as well about your experiences. I'm sure others would benefit from it. So these platforms were selected based on their existing deployment and flexibility and adaptability for COVID-19 use cases, as well as their ability to support multiple languages and stakeholder interest in actually using these applications and adapting them for COVID-19. So as we will discuss shortly, each of these platforms, they may be applied for COVID-19, but they're really optimized for different functions. And they can be repurposed to a range of use cases with varying level of efforts. And that's, I think, a critical piece, with varying level of efforts, because in our initial conversation with the platform developers, we asked, so can you do this? And they said, yeah, sure, we can. And we said, okay, so how long would it take? Well, and the response ranged anything from 48 hours to maybe a few months, right? Which in the current time is probably too late. And so we were really focused on how quickly can the platform be reconfigured to serve a current purpose that might be fitting for COVID-19 response. So I'll talk briefly through our process as we reviewed these platforms. We reviewed publicly available demo videos about the platforms and how they adapted for COVID-19 use case. We also downloaded the platform and worked with it ourselves where possible to understand dependencies, usability, possible barriers to use for each platform. Some shut down the minute we downloaded them, and we had to follow up and troubleshoot to actually be able to work with them. We conducted interviews with the platform developers and stewards to get clarity around functional and non-functional aspects that are of particular importance. And then we also reviewed documentation and community engagement to get a sense of what the community engagement around the platforms were on platforms such as GitHub and their wiki pages. And we are in the month of September already, and this information is current as of July. And I note that several platforms are rapidly building new functionality. And so if anything is of interest from your perspective, I would recommend reaching out to the platform developers and getting more information. So what are the use cases that these platforms are adapted for? The first is COVID-19 case management broadly, where the application can enroll a suspected case, capture demographics, risk factors, exposures, symptoms, maybe create lab requests, maybe it's a paper-based lab request, as well as support maybe alternate way of diagnostic testing. So there is one platform that guides the healthcare worker on how to get a sample and the duration of waiting to get a confirmation, for example. So it's not really, it's the process of swabbing essentially, not lab testing. And the case management might also serve as the first step for linking these confirmed cases to contacts through contact listing, so mere listing of the contacts. Second is contact registration and follow-up, where there is active case detection through contact tracing activities, such as identification and follow-up of the contacts of suspected or confirmed COVID-19 cases. And this might be done through SMS or through WhatsApp, through phone calls, or through other systems of communications. There is the port of entry screening, which is, I think, one of the first functionality that was quite widely deployed, where the application may support enrollment of travelers who have visited high-risk locations at the port of entry. Event-based surveillance system, where the app may support reporting of aggregate data on individuals with symptoms or with a confirmed lab test, and allows a district or higher level tracking of confirmed cases and contacts. And then there is lab test tracking, so linking the patient and the healthcare worker to the patient sample that's sent to the laboratory for testing. And the application may provide guidance on the method to collect a sample, as I mentioned earlier. And this may or may not be integrated with the case management. There is healthcare worker training, where the application may be adapted to country-specific content to train healthcare workers on appropriate symptom monitoring or use of PPE, personal protective equipment, safety protocols for facilities, and so on. And then stock tracking, an application that may support registration of healthcare facilities and help in the collection and reporting of data on COVID-19 specific resources. So we didn't dig deep into all of these use cases for the purpose of our report. We really focused on the primary use case, which was of case management. So if you see here the figure on the right-hand side, we have Grace, the patient who comes to a healthcare facility or is visited by a healthcare provider at the community level and undergoes a process of registration, getting information around risks and symptoms of the patient and other symptoms, ordering of lab, which information is sent and aggregated at the systems level, documenting, so this is the process of contact listing, documenting all of the contacts that Grace might have been in touch with. And that's also populated in a digital format with a queryable record for each close contact who can be followed up with maybe an automated system like SMS or with the help of contact tracers physically. And then going back to Thomas, the provider, there may be options to provide the patient with educational materials on reducing transmission, perhaps support for quarantine or self-isolation as needed, as well as to schedule follow-up with the patient. And at the systems level, of course, we'd like to view the data and see aggregate information. So this is the primary case that we studied the various platforms for. Okay, so I'll go over the systems quickly to introduce them, and then spend a bit more time talking about the criteria for assessment later. And several of these platforms have actually been built, built a case management and contact tracing use case based on WHO's FFX protocol, first few cases. That's the protocol that was set out. And so that standardized data that was recommended, and they luckily follow that. So ComCare is one that several folks might be familiar with, and it is an offline capable mobile data collection and service delivery platform. In the past, it has been used for everything from simple surveys to longitudinal data tracking. Its strength is that it has a straightforward application builder that allows for easy digitization of surveys and forms, as well as possible integration with digital support, decision support system, notification, and SMS messaging. So the COVID-19 response activities as of July, and ComCare was about in 30 countries, and they had several advanced turnkey-ready COVID-19 solutions. Some of the solutions are being deployed across states and counties in the United States, and it is, as we know, one of the oldest and most mature platforms. In the case of COVID-19, it certainly is as well. Community Health Toolkit also is an open source platform that is designed to support community health systems geared towards more community outreach. And it has several use cases that are built and ready to go. At the time at which we spoke to them, they had port of entry screening with with fairly advanced protocols in Nepal, Kenya, and Niger, as well as rapid plans to develop and scale up their COVID-19 case management, a home-based care module, as well as healthcare worker training module. And it's meant for it has built-in mechanism for two-way communication via messaging, as well as experience integrating with RapidPro for SMS communication, which is a great strength. DHIS2 Tracker, which is distinct from DHIS2, which is used for aggregation at the district level. So the tracker is an open source web-facing application that supports data collection and analysis of transactional or disaggregated data. And the core DHIS2 Tracker software development is managed by HIS, by the University of Oslo, whereas the DHIS2 is a district-level health information system that's used across several countries. So in practice, the DHIS2 Tracker is used for tracking individual data and can be used in a community or facility setting. And the COVID modules, DHIS2 Tracker as a whole is deployed in 52 countries in 17 Indian states, and the COVID module in about 28 countries. And they also have several mature use cases developed and ready to go. One of the strengths of DHIS2 is that it has a fairly advanced community of practice, and it's easily configurable with multitude of features. So we looked at Go Data, which is a fairly easy to use case and contact data collection and visualization tool. It allows you to actually visualize disease transmission and has functionality for case investigation, contact follow-up. I mentioned about the chains of transmissions, and it was used in the Ebola outbreak in DRC. It, again, like ComCare and DHIS2, is highly configurable with several features as well as several turnkey-ready COVID-19 applications. It also has sophisticated built-in analytics with visual summaries of cases that need follow-up, which can be helpful. So one other point at the time that we spoke to Go Data, of course, it's hosted with the WHO, and I should point out that that several of these platforms are or were providing pro bono support for adaptation, configuration, deployment of the tools if needed. So ODK is, again, one that several of us might be familiar with. It's open source, I think traditionally used for data collection using Android mobile devices, and to submit the data to an online server is effectively usable without internet connection. So ODK's strength really lies in its global community of developers, which is very, very advanced compared to other platforms that we looked at, as well as the ease of adaptation of the platform. It doesn't need advanced software programming skills at all. It is not something that is necessarily recommended for longitudinal client follow-up. It is primarily optimized for cross-sectional point-in-time data collection. So yeah, so that's its, I think, primary use case. It was being deployed in several countries when we spoke to them, but because it is truly owned by the implementers, it was difficult to document all the deployments. And so there isn't a listing of the numbers or of the countries where it's deployed necessarily. So I think several of you might be aware that in ODK, you can create forms essentially on Microsoft Excel and now on Google Sheets and directly upload it to the server to create the forms for data collection. So moving on to Opensrp. which is also an open source mobile health platform that allows frontline health workers to electronically register and track the health of the population. It was primarily being deployed in Indonesia with about 200 healthcare workers and was in the early stages of development for COVID-19, though very advanced functionality as far as lab test tracking goes, definitely worth looking into for that purpose. And they had planned modules under development for contact registration follow-up and event-based surveillance system. So moving on to RapidPro. RapidPro is quite distinct from the other platforms we've talked about so far. It allows users to visually build a multi-channel two-way messaging bots. And the bots can be run on SMS or WhatsApp, IVR channels, among others. Using RapidPro flows, I see somebody looking to be admitted. Users can build sophisticated time-based questionnaires, as well as campaigns, other interventions in minutes. It's really quite user-friendly and advanced messaging capability that can be easily customized and deployed. Several of the other platforms that we've talked about, it's possible to integrate them with RapidPro for the purpose of building out this messaging capability. And RapidPro does have a very large global community of implementers. Sourmaz is, again, an open source Android and web-based platform. It was developed for case management, contact tracing, and surveillance with a fairly advanced laboratory module for management of lab samples and tests. It was used extensively in Ebola response, and you'll see that it has sort of a different setting for deployment, where it's been deployed across high-income and low-income settings: Nigeria, Germany, Ghana, Fiji, France, and Switzerland. It is very much set up for use in a healthcare facility setting. The application has some advanced features. It supports appointment scheduling, healthcare worker task catalog with reminders. It has an interface with R and can be integrated with other data analysis tools, as well as has pretty sophisticated built-in analytics for visualization of patterns for COVID-19 transmission. And then finally, Veltel, which integrates virtual care and patient engagement, connecting remote outpatients with the healthcare system using their phones. So it is a browser-based interface that can be used on a desktop or a smartphone. Again, Veltel is quite different from other platforms because it is browser-based only. It is a browser-based interface. It's not available as an app. Basic phones can be used. So if patients may have basic phones and may receive SMS through the browser. And patients do not, so they don't, the benefit is that patients don't need a smartphone to connect to Veltel's system. It also supports appointment scheduling and reminders, and broadcasts videos or public health information on a secure patient portal. All right, I see that there are some questions, and I am wondering if we should take a brief break to actually, I'm trying to see if I can see.
I'm fielding the questions as they come in, so we can keep going, I think, till the end, and then open it up.
Okay. Okay, great. So I'll keep going. So on the surface, these platforms, they appear to have a lot of similarities, but as you can imagine, given the surface level similarities, it can be quite difficult to make sense of what would optimally work in a given context. All of these platforms have functions that are suitable for the primary use case of case management, contact listing, and notification. ODK, like I mentioned, is primarily optimized for data collection about cases and contacts and is not optimal for a clinical setting where longitudinal follow-up of patients is expected. And then RapidPro is primarily optimized for remote communications between clients and healthcare providers. So the factors that might lead into the process of decision making might include the system that a country already has in place, has experience with, has local developers that have experience with the system. There might be others, for example, the type of mobile phone that the system works on. Veltel, for example, is browser-based and would require on the healthcare facility side smartphones. We might also consider whether they have a messaging functionality, and then how optimally the system works in an offline environment. So whether data can be transferred via Bluetooth, for example, might be something that might be of relevance. So you'll see in the report, which I see being discussed in the chat, though I haven't read the discussions, in the report, we do go into a lot of detail into each of these aspects, and we talk about which of these platforms have any of these functionality, which you might find useful. So it's worth looking at the tables and see if the functions are what are of interest. Great. So next is we also assessed based on non-functional characteristics all of these platforms on a maturity scale of 0 to 2, with 0 indicating that the functionality does not exist and 2 indicating that it is a well-developed functionality. And much of the report is focused on these non-functional characteristics that I will go through now. Oops. Okay, so getting into the non-functional requirements, these are the range of non-functional requirements that we looked at: usability, documentation, whether there is an open access, where it is open access and has a developed community around it, of course, standards and interoperability, everything ranging all the way going to cost considerations, and we can dig into the weeds in the next few minutes.
And this really is an important slide. I mean, in terms of a slide, I think the report contains a lot more detail about those specific domains. A few people were asking about indicators and checklists to evaluate software. And I think the report has a lot of useful, across all of the domains you just shared, some really useful indicators and checklists that could be used.
Yeah, absolutely. So if these 9 platforms are not, none of these platforms are of interest from your perspective, the checklist and how all of these non-functional characteristics have been broken down into component parts might be useful, something to consider as you're doing your own evaluation. Absolutely. So I think usability is a easy one. It is features that make the platform intuitive for a user, and we defined a range of subjective and objective criteria for usability. So for example, speaking of indicators, graphical user interface, whether the form is available on mobile or computer, what does the search interface look like, whether there's real-time data validation, ease of use, the notification, whether there is a notification of changes made, ability to change font size and icons. So we've used sort of a mix of subjective and objective criteria to define usability, and we found that most of these platforms are easy to use. They have relatively an intuitive user interface and easy navigation. They're also mostly configurable, though some have several more features like DHIS2, Go Data, come to mind, ComCare. I think they have several more features than others. They're also available with multiple language packages, which means, or are easy to translate, which makes them easy, can be deployed with much more greater ease in different settings. So again, documentation is, as we know, the shortest distance between 2 points is the way you know. Okay, great discussion that I'm missing out on, but I look forward to reading it later. So we know that documentation is one of the hallmarks of software maturity. And having adequate, updated, clear documentation, it does facilitate not just the installation, but also the customization of the software. And we found that all the platforms did have standard user and technical documentation available. Open access and developer community. I think this is often a misunderstood concept, and so maybe it's worth talking about a little bit more. Several of these platforms are open access, are open source. You see the names here. Veltel is proprietary. GoData is free for use, but currently the source code are not freely available. DHIS2 Tracker, ODK, RapidPro. So we looked at not just whether they were open access, but whether they had a developer community that can facilitate uptake, adaptation, and implementation of the platform. And so from an implementation perspective, it might be fairly challenging to adapt to software if there is inadequate documentation and no community around it. And so depending on the maturity of the developer and the user community around the platform, new use cases may actually place a pretty heavy burden on the team undertaking the customization for the first time. So to Derek's point of the shortest distance being, I guess, the one that you know. And so familiarity with how to use the system is definitely helpful. And if there isn't a community around it, it might be open source, but not very useful to actually use it in country. Of course, open source has benefits. The system can be stood up, adapted, and owned by the implementing group, possibly at a lower cost. So what we have here is DHIS2 Tracker, ODK, RapidPro. We identified as having the most active global implementer community. They have local expertise to customize and support without active involvement of the steward organization. And so there is a range for these platforms. Some are advanced enough that you can take them, run with them. I mentioned that ODK and RapidPro don't even have documentation of where they are deployed because they are not involved with the deployment at all. Whereas there are others that the community is fairly small still. It's actively growing, but fairly small. But you can come to a point where if you need to make a change in the form, you might actually have to reach out to one of the developers, the steward based in the US, to make the change. So reliability is next. And it's the ability of the system to run consistently without failure. All the 9 platforms can be deployed on the cloud. They allow data to be stored locally and uploaded when connection is available. There are 2 aspects of reliability that we looked in, because in the community there's quite a lot of interest in how well these platforms can function in an offline environment. And so there are 2 aspects of low connectivity environments, and I have to state up front that this is fairly complicated, because you'll notice that in the catch line for these platforms, most state that they are built for low connectivity environments. But what does that mean? And how can we break that down into what does that mean for the users of the platform? So over here we've gone as deep as two criteria. One is, how are duplicate IDs used? So for example, if a healthcare worker or if multiple healthcare workers are working in an offline environment, will there be duplication of IDs? And what is the system in place to actually prevent duplication or to identify duplicates and deduplicates? And we talk about that in the report. It might be helpful to look at. I think all applications do have a method to flag duplicates. Some have more advanced methods that they can be quite clear about to prevent duplication of IDs. The second is where connectivity may be a problem, the process of data transfer and system updates needs to be clearly articulated. So for example, if network connectivity is available within a short distance from the end users, most platforms that are assessed here, they can upload the data to the server base locally or on a secure cloud or both. But in the absence of constant reliable connectivity, there is a need to use alternate methods to upload data to a local node. So a local node might be a laptop in the hands of a supervisor, and that might be done using USB or a Bluetooth connection, which is then synchronized with the internet or a system server by traveling to a connected area. So only ComCare and Opensrp have one or more current instances where they've attempted this idea of peer-to-peer Bluetooth data transfer, and others haven't. So I think that can be another sort of distinguishing point in terms of optimization for low connectivity environments. Though having said that, Bluetooth connection isn't the only way, I guess, to work in offline environments, others would argue. So scalability, it is the ability of the application to continue to maintain its performance over time under different settings. And this does require that the application is consistent and does not crash or stall as the number of users increase. The Community Health Toolkit, CHT, DHIS2 Tracker, and ODK, they've been deployed to tens of thousands of users. The largest instance of ODK hosts more than 80,000 users. DHIS2 Tracker hosts 43,000 users. ComCare has 28,000 users. So they are fairly scaled applications. Standards and interoperability. I think this was a tricky one for everyone because it's tremendously challenging, not just from a technical perspective, but a lot of the health data standards are not defined in several of the countries where we work, and of course the upfront costs of having these in place are tremendous. However, over the past most of these platforms, they do adhere to global norms and standards to facilitate operations with other healthcare systems. I've listed here the ones that do comply with industry standards for healthcare data exchange. And several of these systems have at least one instance of integrating their system with DHIS2, which is not the DHIS2 Tracker, the DHIS2, or a comparable backend system. So moving on to devices and operating systems, most mature global offerings, they cater to the dominant Android operating system, and they leverage a wide range of handheld devices. Some offer basic and feature phones, support basic and feature phones. So you'll see here a distribution of what that looks like and what phones are supported by these different platforms. Messaging capability. So text messaging is, of course, and I've talked about this a little bit before, so maybe I will skip it, but essentially several of these platforms have the ability to integrate with RapidPro to facilitate two-way text messaging. Analytics. All of the platforms have advanced inbuilt analytics and the ability to integrate with external software like R or Tableau to facilitate advanced analytics. And then finally, cost considerations. So most applications other than Veltel and GoData have free open source licensing. Essentially, they can be deployed independently by the implementing organization if local consultants are available and if local consultants have the necessary expertise to adapt them. If local expertise is not available, the steward organizations can provide the support for a fee. And specific to COVID-19, as I mentioned earlier, these services might be available free of cost. So I've got here the organizations that provide support for a fee. RapidPro, DHIS2 Tracker, they just provide advanced troubleshooting support. Veltel has a tiered subscription pricing model. And then there are others that have service level agreements and so on. So finally, and I want to leave some time, 15 minutes now for discussion. So I'll wrap up here, but we'll see that that there is actually a lot for purpose of COVID-19. We are able to distinguish between these platforms. They all have certain strengths, and they certainly have a very dedicated team of developers in the Steward organization. However, several also, I think the question to ask is what might be fit for a given context and be led by that. So I will stop here. We have the report on this link, and feel free to reach out to me if you have more questions. And I think we can actually turn it over to the discussion. Alain, do you want to? I know you've been chatting, so you know which questions we have yet to get to.
Yeah. So thanks so much, Smisha. And the easy link to remember is here in the chat. If you click on it, it'll open up a window with the report that you'll be able to take a look at later on. But I guess one unanswered question is the one from Derek here, where the number of cases can grow to be quite large, and any of the platforms that we looked at had to manage large caseloads at the time of our analysis. I think certainly ComCare probably was deployed in locations where case counts were high. Derek, maybe you want to speak to that? A little more detail. What's your concern?
There are some situations where, I mean, especially as testing has ramped up, that our populations of tests are very large, and some of the solutions use database backends that are quite flexible, and from that flexibility, you don't have as many indices, or you're not maybe using a strong schema, and depending on which tool is being repurposed for this new use case, it might not have been configured in its original implementation to be handling millions of records. Mm-hmm. If you look at something that was implemented in a regional setting for pregnant moms, it might be handling tens of thousands of records. And when you go through 2 or 3 orders of magnitude with the number of records, it can become very challenging. Right. I just was curious whether you'd found anything, any of them that would started to reach those limits.
No, they hadn't actually. So at the time when we did the report, the case counts were still limited, and I think the scale is a tricky question, because in their internal testing, they have been, several of them, I don't recall which one, but it's in the report, they have been tested with up to upwards of 1 million users, but that's not been the case ever in practice. And I think, I'm not sure if any of these platforms are actually being scaled nationally, and it's only if they are being scaled nationally that there would be an opportunity to test that. But at the time that we were in communication with them, there were plans to, be the primary point, the primary software for port of entry screening and so on. But they were nowhere close to the numbers. As you see, the numbers are in the tens of thousands, not even in the hundreds of thousands.
Fair enough, and thank you very much. And an excellent presentation too. Thank you so much for that.
Thank you. I also see there is question about the minimum number of people you would recommend to be in an evaluation team, and what competencies would each have. Alain, do you want to, or have you addressed that already? Okay, you've addressed that.
I addressed it a little bit in the chat. But I mean, I think it's a reasonable question. I mean, given the circumstances, the intersection of disciplines that come together in digital health. And this report, I think, really illustrates the importance of having people with clinical expertise, people with informatics expertise, people with human-centered and user design expertise, because all of these different facets of construction come together in the final technology solution. And so something, in order for something to work well, it has to have elements of robust design. It has to have a strong usability and stability. It has to have the architecture to be able to survive at scale, as we were just discussing. And so I think each of these skill sets brought to the table come together and form the optimal team that makes up a digital solution evaluation group. And so, you know, I think even the report that you're reading right now reflects that combination of skill sets brought together. I did point out in the chat, there's another report that came out some years ago from PATH and WHO, and I provided the link right here in response to Alvin's question. But it's a report entitled Planning and Information Systems Project, Toolkit for Public Health Managers. And it does remain one of the most articulate and lucid and simplified frameworks, I think, to think through the main questions when planning a project, and whether it's, you know, in terms of an emergency response to COVID, or whether it's in a routine digital environment. That document can be very useful. There's a new version of it that WHO is planning to launch in the coming weeks, hopefully, called the Digital Implementation Investment Guide. So stay tuned for that resource. So we have a little over 5 minutes remaining in the hour. I see we have a few dozen people who have hung on till the dear end. So are there any other burning questions that that we might be able to answer? And the links are here in the chat. And again, Smisha's email is up on the screen. So if you can't think of a question now, do feel free to reach out to Smisha or any of us on the team with your questions, or if you are involved in an implementation and you'd like support in the evaluation of that implementation, the Hopkins, the Global M Health Initiative team is always ready to work with you. Pierre Elias asks a question, Smisha, and maybe you want to take that about PNG with Sourmaz.
I don't remember, Pierre, right off the bat, specific information, but I think because in the case of COVID-19, I feel like things are evolving so rapidly in terms of where these platforms are rolling out. If I recall correctly, Sourmaz was set to scale in Nigeria. I am not sure about the Papua New Guinea and specifically the Pacific. But if you need contacts for Sourmaz, they are highly responsive, and it's actually included in the report, but we are happy to make introductions if that's helpful. Thanks, Derek. We didn't. I'm not sure. I'm not sure if we actually explored trust at all for these platforms, but I do see how it is critical for people to share their information with the platform. Sourmaz has actually, since we're talking about Sourmaz, it has some specific capabilities that are set at rumor detection and misinformation, which I guess might be one aspect that's worth exploring.
I mean, one thing that we certainly are learning, maybe not specific to this particular report, but broadly across our experiences with information systems and the use of digital health for COVID, is that in the absence of public trust, digital systems are struggling to gain a foothold, as we've seen in a number of very sophisticated countries, where the absence of a legal framework to protect individual data and to ensure the sort of the data is not misused or abused by any public agency, or that there are protections around data. Where those protections are not in place, there tends to be a high index of suspicion and a low index of trust, and that does lead to recalcitrance in using some of these systems. In other environments, we've seen, for example, in South Korea, in Australia, where specific legislation that governs the use of digital data to control the pandemic, I think we have seen a more positive population-based response to that software, and I think these are things which hopefully we will learn from this pandemic going forward. That preparation begins now, and as Derek pointed out, not in the throes of the emergency response. It's both Smisha and I were involved in some emergency digital responses in the early days of the pandemic, and the kinds of decisions you have to make in terms of selecting a vendor and deciding on the right workflows and variable names. The onset of a pandemic is neither the time nor place to be making those kinds of decisions in the heat of the moment. So the best pandemic preparedness happens before a pandemic takes place, and hopefully that's a lesson we learn and take to heart going forward.
Great. I think that's a great note to wrap up on. So thank you everyone for taking the time to come, especially those for whom it's late in the evening. And if there are any questions or thoughts, anything that you'd like to discuss, please feel free to reach out, and we hope that this is a useful report for you. So thank you everyone.
Thank you.
Thanks for organizing. Thank you, Alvin.
Smisha, thank you. Alain, thank you. This is an important webinar. We recorded it. We want to replay it again and again with your permission, of course. And some of the AHIN members are actually part of the interagency task forces in the different countries. So this will be shared widely with them also. And I hope you can stay connected with us. We will have a need for JHU and mHealth group over there to help us with some of the advising that we will give to our ministers of health. So thank you everyone, and good morning. Take care.
All right, bye-bye.
Take care. Bye.